Good evening, everyone. A warm welcome to tonight's VIVA Asia Educational Forum webinar, which is brought to you by the VIVA Foundation for Children with Cancer, Jude-VIVA, and the Asian Childhood Cancer Alliance. We are very excited tonight to have with us very esteemed experts. It is with great pleasure for me to introduce Dr. Shweta Bansal from the Sir H.N. Reliance Foundation Hospital in Mumbai, India. So I'll hand it over to Shweta now.
Yeah, hi, thanks, Lai. So hi, friends, a very warm welcome. We all are looking forward to this exciting, insightful educational activity, and we are very thankful to VIVA Foundation to support it. I would also like to thank ECA Group, May and Sally for giving me the opportunity to chair the session. So regarding LCH, I would say it is an enigmatic disease, and the doctors from different specialities, be it pediatrician, surgeons, ENT specialists, skin specialists, they come across a case of LCH sometime in their practice. Since LCH has varied presentation and it can affect any organ of the body, it's a neoplastic process or it's an immune disorder, it's always a debate. LCH can affect skin, lymph nodes, hematopoietic system, any part of the body, you name it. And considering the varied presentation of LCH, the treatment is also quite diverse. It can range from just observation to curettage to excision and chemotherapy, which can range from 6 months to 1 year to 2 years. And sometimes it may require bone marrow transplant also to cure the patient. Hence, understanding the disease pathophysiology and principles of treatment, it is important and to correctly treat a patient. And who can tell us better about this disease other than Prof Quah himself? Prof Quah is a senior consultant from Division of Paediatric Oncology and from the Department of Pediatrics, National University Hospital, Singapore. He is also an associate professor of Yong Lu Lin School of Medicine, NUS. He grew up in beautiful island Penang in Malaysia, and he came to Singapore in 1971 to study medicine. He was captivated and inspired by Prof Wong Hock book, and he always considered him as a walking encyclopedia. Those who know Prof Quah, they will say themselves that Prof Quah himself is no less than an encyclopedia. Prof Quah always tells us that Prof book motto was, if you want to do pediatrics, you get to live pediatrics, eat pediatrics, and sleep pediatrics. And Prof Quah himself leads by example. In 1976, Prof Quah completed his internship in Singapore General Hospital. And in 1983, he started to devote his life to pediatric hemato-oncology. And he nurtured the division and brought it to the heights where it is today. I consider myself fortunate that I had the opportunity to work and learn under his supervision. And I can vouch that he is the finest mentor and has a knack of bringing best from the people. He is cool, never loses his temper, and has deep insights of the subject. He is the epitome of humility and excellence, and these qualities has brought him many accolades. And he has received National Medical Excellence Award in 2013. It's my privilege and honor that I'm chairing this session today, and I would like to invite him for his deliberation. Prof Quah, over to you.
Last line, I'll be very glad to share my papers with you and whatever things you might want to ask. Thank you very much. So on to Shweta, yes.
Yeah, Prof, thank you. Thank you so much for such a wonderful talk and such a beautiful talk. It's very well presented and simplified, such a complex pathophysiology of the disease.
Since you haven't the switch to your screen, this is my last slide. Yeah, so imagine some of you might be doing as this lady is doing on the other side, but that's okay. It's quite late now.
No, I don't think so. I don't think
okay,
so.
go ahead,
Everybody was well awake. Yeah. So we learned a lot actually, and I really like the last 2 slides. Actually, medicine is a practice of mind, heart, and soul, and we have to treat the patient as a whole. So for a few takeaways for me is what I understand from your talk, and I'd like to summarize a little bit. So LCH is having two types of behavior, I would say, from what I got from your talk. One is a good behavior and other is weird behavior. And it depends upon the pathophysiology from where and which part of the cell or the system they are getting engaged into. So if they are engaging the early part of the hematopoietic system, the disease is more aggressive. If they are engaging the later or mature part of the system, then the disease is single system and less aggressive disease. Then there are multiple pathways which are involved in the pathophysiology. And definitely, as you made us understand, that LCH is not a cancer. It's more of an inflammatory disorder, and it has a cellular. So the three words which we learned is cellular, transcriptomic, and epigenomic heterogeneity is there. And they don't have recurrent somatic mutations. Most importantly, what I learned today is that we need not to do biopsy for all the patients. Those patients who have burnt lesions already, they need not to be treated. They can be just followed up. And the patient, if you don't have a immunophenotyping, if you don't have a flow cytometry, and if you don't have other gadgets to diagnose the patient, only by the clinical history and the clinical presentation, if it points towards the LCH, you can treat accordingly. So, Prof, anything else you would like to add
Thank you very
in
much.
the summary?
You've done a good job. Yes.
Yeah. Okay, so now coming to the question session, there are a few questions from the audience. Question number 1 from Dr. Amol. He wants to understand what is the standard complete protocol for low risk and high risk LCH.
Okay, you can go online, Google LCH protocol 4. Yeah, and the details will be there. This is the most detailed, fussy, so I can say fussy protocol for LCH ever, but that is what the LCH needs. Yeah. Okay, so interestingly, for the single organ and single lesion, the proposal is you may want to watch and see. Yeah. So for the rest, it's still mainly vinblastine prednisolone based, and with early monitoring, and if the response is not so good, the response to treatment is said to be the most important prognostic factors. If it's not so good, then you will go to a more intensive protocol. Yeah. And now it is proposed to be those who need it 1 year more than instead of 6 months, because protocol 3 shows that 1 year is better than 6 months, although not by very much.
And thanks, Prof. So second question is from Dr. Maria. She wants to know how many LCH patients have you seen presented with chylothorax?
I have never seen one. Chylothorax is a bit peculiar, right? If they have just the pleural effusion, that's understandable. I'm not sure why you get chylothorax unless there's some solid lesion that is obstructing the bowel flow. No, not the bowel flow, the thoracic duct. Yeah. So you may have to do, discuss with your radiologist to see what imaging he or she can do, to see whether there's any blockage.
Okay, so next question is from Dr. Low. She is asking whether should LCH patients have genetic screening for the specific genetic mutation, in particularly the BRAF mutation, in order to use targeted therapy?
You see, it is said that even though if you test for them, different the figures, the high risk you can detect more easily, the lower risk not so much. So it's the high risk patient that are much more likely to require target therapy. So almost 100% of them, should have this the mutation. So even though you don't detect them, that doesn't mean that they are not there. You may be biopsying the wrong place, or the lab may not be up to par. Yeah, so it is just like giving this pembrolizumab. So it is said that the correlation with the expression of the PD-1 gene is not so great. So if you can do it, good. If you can't do it, just go ahead and treat. Because in the end, the endpoint is said to be the ERK, their activity, which is the increase by the mutations along the signaling pathway. So whether it is up there or lower down, this targeted therapy should work. Even though we know that this drug is very expensive. And secondly, when you stop the treatment, the evidence is that most kids would recur.
Yeah. So next question, interesting question from Dr. Risky. She's asking, can vinblastine be replaced with vincristine?
Yeah. My gut feeling is yes. You see, when I first started my practice, as I said, there was no internet, no nothing. Yeah, so you got to have everything hard copy. I used to have 6 filing cabinets. So when we moved from the old hospital to a new one, my present office room is too small. So I got to very, very sad. Yeah, I got to throw away all my files. So nowadays, I look back. In fact, when I was preparing this talk, all along I've been thinking, yeah, when preparing this talk, I was looking at the literature again, but nobody talks about this sort of thing now. But my gut feeling is you can. Yeah, so I know that I think in many places, vinblastine either unavailable or more expensive. Yeah, so I would have no, I won't be conscience stricken if I use a vincristine.
Okay. And next question from the same Dr. Risky is multi-system multifocal LCH with liver involvement, where the liver function test is increased. Is it necessary to adjust the dose of chemotherapy, or can we give the full dose?
You see, the liver involvement, there are 2 main types. So one is the parenchymal involvement. Yeah, one is the biliary involvement, which some people call sclerosing cholangitis, which is a very difficult thing to treat. You see, I have a few patients died on me. The first one was a child who, on thinking back, probably died of HLH. Yeah, you know, LCH can trigger off HLH. So the 2 of them died because of liver. Scary. Yeah, it's very difficult to treat. Yeah, but more recently I've seen kids with liver involvement who both biliary and parenchymal who respond to treatment but are left with residual fairly mild liver involvement, meaning the hepatic fibrosis, a bit of hypersplenism, but the LCH is quiescent. Yeah, so the management now is not so much me, but my friend, the hepatologist. So when you have as far as the drug adjustment in hepatic involvement is concerned, we are more concerned about if the child has the increased bilirubin. Yeah, we are very careful because then the excretory function is affected much more. Yeah, so the hepatic function, ALT, AST, officially, conventionally, people say if it is less than 4 times the upper limit of normal, it's okay. But I hear many experienced oncologists who told me and said, usually it doesn't matter. So we don't even bother doing the test now. Yeah, but of course, you know, if the ALT, AST levels are high, you might want to reduce the dose a bit and then see, yeah, whether the toxicity profile is worse. If it is not worse, then you slowly increase back to full dose.
Thank you, Prof. So next question from Dr. Hong Nam. Can you share your experience with lung LCH?
Lung LCH is particularly more for adults. Yeah, in kids, I've seen only 1 patient. Yeah, and the child is well. And the literature is that at one time, people thought that lung LCH in kids are bad, but it seems that over long term, the results are not that bad. So it's not considered as a risk organ. But if child LCH, lung LCH, then what you need to do is, of course, to share your work with your friendly the lung doctor, yeah, to follow up with lung function and maybe the CT of the lungs.
Okay. So next question from Dr. Radhian. She is asking, can you determine which lesions should or should not be aggressively treated? Is there any involvement of polymorphism, ethnicity? Also, she is having a patient with early lesion LCH with persistent fever and recurrent anemia. She's asking whether you can suggest an aggressive or more conservative treatment for this patient.
Okay. Yeah. So the aggressive treatment would be the risk organs, which would be the bone marrow, the liver, and the spleen. Yeah. Other than that, then you can be a bit more relaxed, unless they don't, as I said, the response to treatment is one of the most important prognostic factors. So you got to monitor your kids carefully. Yeah. So the early lesion with fever and recurrent anemia, I suppose it means that this is an active lesion. Yeah. So you may want to attempt more immunosuppressive treatment. So the steroid should work well. Yeah, and if doesn't work so well, usually our second line used to be CDA. Yeah, I've used verumafenib and more recently the dabrafenib in some patients, and it's easy to use. The biggest problem is the cost, and the second problem is it seems that they don't cure the disease. Yeah, but you know that the LCH, most of them would burn out over time, so it may not be such a big problem. So again, this is also another reason why we must follow up every patient, because they behave differently. So if the intent is a cure, hopefully to reduce the chance of relapse. Yeah, I love CDA. If you use it well, we just practice outpatient treatment, and very few of them have any significant side effect. Yeah, see, I like the metabolites in general, because they don't cause a DNA damage usually. Yeah, so you don't get the usual side effect that you get from alkylating agents and anthracyclines, secondary malignancy, infertility, and such things. Yeah, so so CDA belongs to the same class. Yeah, of course, the CDA is fairly expensive too. Yeah, so in my younger days, I saw a lot of patients, the bad ones. During those times, there was no CDA, there was no, I remember there was one, yeah, whom I saw as a baby, and she was with us until she was about 12, and she never stopped treatment. Wow, so I got to scratch my head and think of all sorts of treatment for her. So she was given indomethacin, she was, I think, given interferon too, she was given cyclosporine. So and then finally the CDA came along, so I gave her CDA, and after 6 cycles, everything settled. So none of my patients respond within 2 or 3 cycles, and that is the general experience. So you got to be patient and continue your treatment. Yeah, and so nowadays, if you have the targeted inhibitors, if the disease is aggressive, is fierce, yeah, the child is sick, then you might want to try the earlier.
So, Prof, another question regarding liver disease only. One is that in the multisystemic disease with liver involvement, with direct hyperbilirubinemia, maybe 20 times more than the normal, is it safe to use vinblastine?
That
and another question
I don't know. I would be very careful. Yeah, because vincristine, we know that vincristine, when there's liver dysfunction, you must be very careful. So I presume it is the same thing for vinblastine too. Yeah. Then if the child responds to things like the steroid, that'd be very good. Yeah. So I would just treat gingerly, and then of course, if we ask the hepatologist to help, they will say, "Oh, okay, please give the child some ursodeoxycholic acid." Yeah, that's one of the drugs that they love so much. Yeah.
So first tide over the crisis and then go for the aggressive treatment, you are suggesting.
Right. Yeah.
So in case of isolated liver involvement, is it important to do liver biopsy as the first diagnostic procedure?
You see, if it is the biliary involvement, usually the peripheral tissue that you get in biopsy don't tell you anything. Yeah, and very often the LCH cells, if they were there, by the time you biopsy, they would have gone. Yeah, so what you see would be the burnout issue. So if the biopsy, if you have a good surgeon who can do the biopsy for you, you go ahead. But if it is difficult, then I don't think it is strictly necessary.
Okay. So another question, in a LCH with small lesion, a small volume lesion, less than 3 bone lesions, without any high risk and organ involvement, but painful bone, will you watch and see while only offering short course NSAIDs and monitoring, or anticipating spontaneous recovery, or should we treat it as symptomatic indicating active LCH?
Is this exactly the sort of case that you want to try and see? Yeah, I think the NSAID is lovely. Yeah, I mean, NSAID is not only for the pain, yeah, but it can also heal the bones. Yeah, and I have a patient with a very extensive bone lesion, and she had it nowhere else. Almost half the femur was gone. Yeah, so she was not allowed to walk even. Yeah, so in the end, and she was going for op. So of course, then we dare not give her steroid. We dare not give her any aggressive treatment. So I gave her biphosphonate, and she healed very well. Yeah, so it's not only of pain, yeah, but it's also, it helps the healing of the bones. Yeah, so I expect that the NSAID will do the same thing. But if you want the pain to respond even faster, then a steroid for just a few days, I think will do the trick.
Prof, is there any role of COX-2 inhibitors in this case?
Yes.
Celecoxib and all those things?
Yes. Yeah, but of course there have never been any big trial. Yeah, I still remember in the old days, yeah, people use indomedicine. Yeah, I don't think that this is better than anything else. You just try.
Okay. So another question from Dr. Sanjeeva. Is there a role of radiotherapy in treatment of relapsed LCH?
Again, this is a very individual decision. Yeah. So if the bone lesion is causing a lot of problem, yeah, like the girl I was talking about, yeah, you know, half the femur gone, yeah, then a surgical procedure would be ideal. Yeah, but if it's a small bone and causing pain, then I would rather give either NSAID or steroid. Yeah, but if it's just one bone alone, then the curettage alone plus minus injection of steroid might just do the trick. Yeah, so I see very little role for radiotherapy now, and I've never sent any one of them for radiotherapy because they are good alternatives. I presume unless the bone is deep inside, so the surgeon will say, oh, it's too dangerous, not too nice to do a curettage. Yeah. So there are so many. So for many questions in life, you know, I decided the answer is the devil is in the details. Yeah. Where, how, yeah, progression, and how big, yeah, whether there's any pain, other circumstances. Yeah.
So, Prof, another question from Dr. Maria. Have you seen a pattern of longer symptoms before diagnosis? And do they have more severe and more difficult to treat?
You see, the longer ones who see you are those the progressive one. So if you read the paper, you're saying, oh, okay, yeah, many of the cells are the S1, 2, or 3, the early cells, they continue to grow. Yeah, those who don't continue to grow, you don't even know. They might heal on their own. There are probably a lot of kids they are out there, yeah, who have LCH and nobody ever knows. So if they continue to grow, yes. I remember there was a boy from Indonesia who had this scar lesion. So the worst thing that they can do is to see the neurosurgeon. Yeah, because I've seen more than one case where the neurosurgeon would just remove the skull and just put a mesh there, you know, without the, yeah, I don't know. Sometimes I believe that they don't even send for histology. Yeah. So this kid was going around for 1 or 2 years. Yeah. And then he came to Singapore, and then he saw my friend, yeah, who told him this is histiocytosis because this boy has the DI at the same time, which the doctors in the other country didn't even ask for. Yeah. So there are slow growing cases, but not aggressive in that sense. You know, it's just a Hodgkin, they grow slowly. Yeah, they may not give you fever. Yeah, they may not affect wrist organs. Yeah, so these kids just are suffering. Yeah, being bothered. Yeah, okay. So, but they still respond to treatment.
So, Prof, next question is regarding the monitoring. So, Dr. Trixie and Dr. Anwar, they would like to know if the patient is having a bone lesions or hepatomegaly. After finishing treatment, do they need further treatment like extending the mercaptopurine, or how should we follow them and monitor their response?
Again, it depends on so many other things. Yeah, what is the cause of the big liver? Is it because of the steroid that you give? Yeah, because if there is a liver involvement, if the real ALT, AST are raised and bilirubin, then you really have to try very hard. But what I have learned is that there are liver involvement and liver involvement because there are some with some transaminitis, but they are not too bad. As I said, some of them eventually settle. They are just left with the hepatic fibrosis, maybe hypersplenism. Yeah, so the lesion would just settle, become quiescent. They don't even need any treatment. So the one thing you want to ask yourself is whether the lesion is still active. If they're active, then certainly you would want to give further treatment. If they are not active, then you just watch because they might reactivate.
Prof, last question from my side. So if the patient is having a diabetes insipidus, they are more prone to have a neurodegenerative disease.
Yes.
So how many cases of neurodegenerative cases, I mean the progression to neurodegeneration we have seen, and how to follow up these patients and how long to follow up these patients?
ND is so interesting. It is said that there are 3 types. Yeah. And the most scary type is the one that affects the dentate nucleus and surrounding brain tissue. And these kids are left with it affects their mental ability, it affects their physical ability too. I have one, it progressed slowly. Yeah. And this child eventually died of aspiration pneumonia. So there is still no good treatment for this. Yeah. So for many of these things, I think the best thing you can do is to refer to the LCH protocol 4 and see what the Dr. Carlos and Minkov are doing. I don't think they have anything new to offer because it's just doing this and that to see whether it works better than the other treatment. Yeah. So one thing they suggest is a regular monitoring of MRI. Yeah, but of course a lot of the places, the MRI is too expensive, and also many instances there is a poor correlation between the MRI picture and the physical manifestation. So yeah, I've seen kids with very scary MRI, looks very abnormal, and yet these kids are okay. So this is something that we are still trying to understand.
Okay. I think, Prof, last question of the session,
yes.
I guess. So it's from one minute. It's from Dr. Medina. She's asking, can you use CRP or ESR to monitor the activity of LCH?
Yes, you can. But what you do depends on your circumstance. Yeah, you see in here, we have FBC by finger prick, yeah, which the kids love much more than taking the blood from the vein. Yeah, so I just do FBC. Yeah, but if in other places where FBC are taken from the vein, and if the cost for FBC is quite similar to CRP, ESR, then you might do it. Because I think they are quite similar. Yeah, I find FBC to be very useful because all these are just reflection of the inflammatory cytokines are produced by the Langerhans cells. Yeah, so this does tell us whether the disease is active. Yeah. So for example, this Russian boy again, yeah, before he went back to Russia, we repeated the scan monitoring, and to my horror, I found that the MRI, there is the solid lesion, yeah, just next to the frontal lobe. Yeah. So, but he is okay, not affected. So I did the PET-CT scan. His blood count, everything okay, no evident inflammation. Yeah. So PET-CT was clear. So it's just a quiescent burnout lesion. So I didn't do anything, and he's still okay. So this, it just means that when you decide on further treatment, whether it's needed or not, it's largely or partly a matter of seeing whether the disease is active. Yeah, by doing your FBC, ESR, CRP, by doing your PET-CT if there's a solid mass, which you're not sure whether it's active or not.
Yeah. Thank you so much, Prof. I think this brings to the end of the session. And I think after hearing this lecture and learning from you, many of us would be much more comfortable in treating LCH from now onwards. And many of the questions which have remained unanswered and come afterwards, definitely we can write to Prof Quah. He's always available and we can ask his wisdom for that. So over to Lei.
Thank you very much.
For the session. Thank you.
A huge thank you once again to Prof Quah and Shweta. Thank you everyone for tuning in. You're invited to fill up a survey form. You'll find the link on our chat box now or on your browser when you exit this webinar. We look forward to welcoming you in future webinars to come. Thank you and good night, everyone.